Thank you, Tim. Doctors, these questions are coming from the middle of the crowd, every one of them. And as Tim said, we've got some great questions. Well, we got a lot of them, so I just ask you to do two things. As he said, you guys figure out who might be best to answer this question, and I'm sure all of you can answer them all. And number two, other than just saying yes or no, be succinct so we can try to get through as many of them as possible, if you don't mind. So thank you all for being able to do this. First question, regarding PLS, how much exercise is appropriate?
Okay.
Just talked about dancing.
Hello. Yeah. So I'll take this one. It's every exercise recommendation, like any therapy recommendation, is individualized to the individual. So it depends on that particular person's pre-exercise capacity. Are they starting from scratch? Are they already in a robust state? So you can't say how much is enough or how much is too much. It's got to be you got to start within your ability, whatever level that is. If it's low, if it's high, start within your ability and increase very gradually. And people who are new to an exercise program always want to, check with their doctor, any restrictions, my heart, and so forth. But so how much is too much? How much is enough? Start within your ability and increase slowly. What is slow? No more than, say, 10% increase in speed or duration or power every couple weeks. So pretty slow. And at that rate, there will be a doubling of capacity over a few months.
How can we discontinue HSP for the next generation? We can't wait to hear that one.
I'll start. Okay, so I'll take a stab at it, okay? I think the way that we can get rid of it is it's going to be 2 or maybe 3 ways. One could be gene therapy. The second could be drug discovery. So I would love to work with companies who already have drugs and we repurpose them or investigate whether already FDA-approved drugs for other indications, other diseases also have utility or, any use for upper motor neurons that are diseased in HSP. So if we can get that, then you don't really need to reinvent the wheel. It's basically FDA approved, so it's going to be off-label use, and HSP patients may actually have access to them. So that would be easy. And gene therapy would be also, potentially straightforward, but of course multiple problems exist. But if we know the genes to be edited or genes to be transduced, with the use of proper viruses, maybe we can get gene therapy approaches. The good thing is SMA has a gene therapy approach. It's been FDA approved. Parkinson has gene therapy approach. So this gene therapy approach is not very new, right? FDA already approved multiple gene therapy approaches before. So there is a road already built before this. So that's why I think repurposing drugs and gene therapy would be fastest way out.
Some people would say that to obliterate HSP, just don't have babies. And I think that is a naive assertion because there are so many de novo cases that we're learning about. So it's never going to leave the genome, not with these particular genes being so vulnerable to mutation. It'll just keep coming back. So ultimately, we needed a solution that's actually going to work regardless of whether people have babies or not. So the sorts of things that Honda was talking about, where gene therapy gets better and better and better so that we can identify the mutations in say in utero, if we can know that this individual has the mutation in utero, and we can have very sophisticated next generation gene therapy to go in at the earliest possible points, hopefully this generation, the current generation, is the last one in which adults are going to have to deal with it, because in the next generations we can get this solved very, very early on.
If I could just add one quick comment to this. So I think I shared the optimism. I'm also a little bit cautious because I know that this is still a very, very long road, and the word easy doesn't come off easily off my lips, because I think that there's a lot of work to do, and I do agree that I think the future lies in treatments that are initiated very quickly after gene mutation is identified, and I think the technology will get better and better, but there is still a long way to go, I think. I think we're all aware of that, but I think we all look to, situations like in spinal muscular atrophy where a therapy is a success. But the situation in spinal muscular atrophy is many ways more simple. So I think it's great that we have these trailblazers for an approach, but the situation in HSP is a little bit more complicated. And I will just add, as a clinician, I think we all focus on the cortical spinal tracts, we all focus on the motor symptoms, but it's certainly true that for the early onset complex forms, we need to restore normal expression or correct the underlying mechanism in diverse brain areas. The cortical spinal tracts won't be enough.
And I'm trying to resist the idea of joining every conversation, but I can't resist here. So we've had a lot of discussion the past couple of days about the future and gene therapy and molecular therapy, small molecule therapies and things like that, and that's in the future. And we don't know how close that is, but we're working to achieve that. But I'm going to paint a picture that's beyond that future, and that is the idea of fetal medicine and maternal fetal medicine. That is, when do we need to treat the person with HSP? We need to treat that person in the womb, ideally, because as was pointed out, some forms of HSP are developmental in the way the nervous system is put together. And then the child exhibits those symptoms, but the problem didn't begin when the child was 1 year old. The problem began early in development. And other forms of HSP are degenerative, and the difference between developmental and degenerative is a blurred line. Some things that are not put together exactly correctly fall apart. And we see that in Huntington's or some of the ataxias. That is, way before there's clinical symptoms, there's evidence of the disorder. So even though the disorder is in fact degenerative, we know that we can see imaging evidence in those examples in childhood. That's a big generalization. So point is, what we need to ultimately do is to not just find these therapies, not show that they work, but in the next future is to apply these therapies in utero, so that the child, that they've been fixed, whether it's a corrective gene process or a small molecule process or a dietary supplement. We don't know yet, but it has to be early in development.
I can't resist. I'll just add one thing. I think that's the ideal scenario, and I think we all acknowledge that would be the new era of genetic medicines, really. But I think we're, in many ways, not so far away from this, from the reality of being able to diagnose a genetic condition at birth or even before birth. So at Boston Children's Hospital, we had a very large pilot program for genetic newborn screening. So you all know that in all states in the United States and many countries around the world, there are certain conditions that babies are screened for. And these are mostly inborn errors of metabolism. And the reason why these conditions are screened for is that there is a treatment for most of these conditions, for all of these conditions. And SMA has been added to the newborn screening in many states because we have a treatment for it now. So I think we'll see this happening more and more, and I think eventually science and society will come to the realization that genetic newborn screening has risks, but it also has benefits. So I think we're not so far away from that.
Some very encouraging answers for us to be thinking about and waiting on, so thank you very much. Any medications for urinary urgency other than oxybutynin?
There are a number of approaches. The next line treatment would be something called Myrbetriq, so that would be the next line. There are other agents too, but oxybutynin, number one. If that is not sufficient, Myrbetriq is number two. And usually, if neither of those are sufficient, I'm going to consult a urologist, because the urologic problems are not simply urgency. Often it could be urinary retention, it could be pelvic floor spasticity, it could be, in other words, urinary retention could be one symptom, and we need to see if there's other symptoms that would make the treatment more complex or more nuanced for that individual. So the short answer is Myrbetriq is the next agent I would use, and if that's not sufficient, I would consult a urologist. Very good point. All these medications need to be individualized for that particular person. If there's a prostate issue or if there's other pelvic muscle issues. But you raise a good point. It must, too much of a good thing is not a good thing.
What happens if your Baclofen pump stops working?
I don't know if Chelsea is still here, but if the pump stops, it could be within hours a medical crisis, and you need to go to the emergency room. And pumps can fail. Usually they don't fail like that all of a sudden, but they usually slowly fail. But if there's an abrupt failure, then a person's going to become rigid. That could be a medical emergency. It's not usually over minutes, but over hours generally, and or a couple hours. And so get to an emergency room, and they would treat with other medications.
His question is, how do they know it quits? Internal health.
There would be a sudden or very rapid onset of extreme spasticity.
My daughter was confirmed for SPG4 at the age of 2. She is now 15. Is there any reason or value in redoing the gene test?
Yeah, so is there any value in redoing the gene test? Really depends on what variant was discovered. I didn't have a lot of time to talk about this morning, but when we discover a variant in a gene, we classify it, and we classify it according to criteria set forward by the American College of Medical Genetics. And we put them into different categories. Some that we're absolutely sure about, we call them pathogenic. Some that we're very sure about, we call them likely pathogenic. variants that we're not sure about, we call them variants of unclear significance, and then variants that we're fairly certain are not associated with disease, we call those benign. So if a variant is in the category of we're not so sure, meaning a variant of unclear significance, there's absolutely a lot of value in looking at this every 2 years or so. So in fact, for our patients, where we do genetic testing, we find one of these variants, and we're not sure, periodically, meaning every 1 or 2 years, we go back and we see if we can reclassify that variant. So yes, the answer is in that scenario, it would make sense.
This question is one that I think there is a second page to, but I have dislocated it. So if, as I ask this question, if whoever wrote this needs to finish it out, please stand and do so. SPG 7, I'm told I have pure, yet some say it's only complicated. What's the difference? Is there one, and I don't know what the rest of the question is, it's gotten.
Well, this business of pure, or what we call uncomplicated versus complicated. Complicated or uncomplicated doesn't mean life is simple. Complicated means that spasticity and weakness in the legs is accompanied by another neurologic feature. Now, so when this classification, complicated, uncomplicated, came about probably 40 years ago.
86.
Yeah, and it was, it's not, and it was way before genes were discovered, and it's an imperfect correlation with the genes. As genes were discovered, then they say, well, this is a gene for an uncomplicated type, or this is a gene for a complicated type. But SPG4, for example, there's an imperfect correlation between the genetic type and whether it's complicated or uncomplicated. So the classic example, SPG4. Most individuals with SPG4 have uncomplicated HSP. However, in the original discovery of the paper reporting the original discovery of the SPG4 gene, at least one of those patients had epilepsy. And since then, other people with SPG4 have been described with ataxia or peripheral neuropathy or extreme involvement of their whole body. So SPG4 is most often uncomplicated, but sometimes complicated. It's not a yes or no. And now let's talk about SPG7, you said. SPG7 can be uncomplicated. It can also be complicated. And it really doesn't matter if it's most often complicated or most often uncomplicated. We know it can be either. It just, one person in the family could have uncomplicated SPG7. Another person in the family can have complicated SPG7. It's just highly variable.
What is the end game?
So can I just add a thought to that last question? So with SPG4, there are over 200 different mutations that are pathogenic. And one might like to think that some of the mutations are complicated and some are uncomplicated, or that the various symptoms could be sorted out relative to the mutations. But it just doesn't seem to be the case. And there may be, as John said, certain people in a family whose symptoms manifest very differently than other people in the family. And when these children started to come to my attention with certain mutations that were very complicated cases, early onset cases, I thought perhaps it was certain mutations that were particularly severe, but no, it turns out that there are plenty of adults with less complicated symptoms who have the identical mutation. So why it is that certain mutations lead to severe symptoms in some patients, but not so severe in other patients is one of the mysteries. And I think mechanistically it's something that we're very interested in resolving. But what's complicated and uncomplicated, I think, as John said, is a very blurry line.
What is the end game for HSP if no cure is found? Bedridden, and a number of question marks.
The vast majority, well, so there are 90 plus types of HSP. More than that. But that's what we know about today. And some forms lead to severe disability. But most forms do not. Now, so most people that have SPG4, it does not affect lifespan and does not affect breathing. And although, I mean, if you don't get enough exercise, you could have cardiac deconditioning, you know, if you're not getting aerobic conditioning. But it doesn't affect your risk of diabetes or a stroke or cancer or other life-shortening processes. And it is not shorten life expectancy. There are forms of HSP, and Darius knows about these and studies these, that can lead to severe disability. And anytime you have a condition that affects swallowing, and some forms of HSP and PLS too, can affect swallowing, and if that's affected, well, that can be a life-threatening situation. They may have to have feeding tubes and so forth and so on. But so most people that have HSP most adults affected by HSP, do not have life-shortening disability.
What are the pros and cons of a Baclofen pump?
Well, I think it's a very nuanced answer to this. I think the first and foremost, what's important is the right patient selection for this type of procedure. So the indication is predominantly to help with lower limb spasticity, and I think the timing and the patient selection is crucial. I'm hedging a little bit because the scenarios can be very different. So there are children who depend on their spasticity in their legs to be able to walk. And by introducing a Baclofen pump or other procedures like a dorsal rhizotomy, for example, that stability or that help they get from using their spasticity to ambulate can be taken away, and that would not be a good thing. So it's something that I think has to be carefully evaluated on an individual basis. And the second point I'll make is Baclofen pumps, just like other procedures, including dorsal rhizotomies, for example, selective dorsal rhizotomies, for example, they need to be done at centers that do them a lot, because I think experience really matters there. And as we've heard earlier, Baclofen pumps can fail, and there can be problems with it. There can be infections. There can be real emergencies. So I think you want to have a team at a center that can handle all of these scenarios.
Can traumatic brain injury cause spastic paraplegia?
Yes, traumatic brain injury can cause spastic paraplegia, but not hereditary spastic paraplegia. Traumatic brain injury does not, HSP is a group of genetic conditions. And now, but buried in that question is, could I have trauma that initiated my symptoms? I had a genetic mutation, and then I had trauma, and trauma set the process off. And that's a very unlikely explanation. So in general, it's very difficult to say no, but in general, trauma is not it can make the symptoms worse. A person with HSP has trauma. Now you could have more symptoms, but it doesn't cause the gene mutation, and doesn't initiate in general. It does not initiate the symptomatic period of HSP.
How realistic is it to believe that a cure for HSP will be found?
I think 100%.
And you're going to take a mic there?
Well, I think with the enthusiasm and the camaraderie and collegiality and all the efforts that we see in the room and in the foundation, I think that hope is very much alive, that can happen. So I would say just keep up the fight, and we've got a lot of good people working on it, and we'll have more people working on it with more fundraising and more effort. I think it's a very tractable problem. These are gene mutations. We know the genes, we know the proteins they encode for. In most cases, we know what the proteins do that they encode for. It seems to me, compared to something like Alzheimer's or Parkinson's, that HSP is a very tractable problem. We should be able to conquer it.
Yeah. So people also say, for example, how hopeful are you? How, is it hope? I mean, I don't think we need to use the word hope. I think we need to use the word plan. We need to have a plan, an action plan, right? And if we make the right action items and move within the path, it's reasonable. So we don't really need to pray for it or have hope for it. We really actually do it. And now we have the tools, we have the models, we have a better understanding. I think the amount of knowledge that we gathered within the last, let's say, 5 years is more than what we have gathered within the last 50 years, The pace is very fast, and that's why now is the time to form the teams, to work together in a more collaborative way, and, to support those efforts. I think we are very close to the finish line.
Any spinal cord stimulation or transcranial stimulation kinds of treatments that you would talk about?
Well, these are so both of these, transcranial stimulation has been studied experimentally to reduce spasticity, and direct spinal cord stimulation has been studied to reduce spasticity. And so these are, I would say, in the experimental stages. There was an anecdotal case report of a person who had a spinal cord who had hereditary spastic paraplegia, and she was receiving spinal cord stimulator to treat chronic pain. And so with that spinal cord stimulator, it also reduced her spasticity. Now that's one person, but there have been other studies. There's a few studies about spinal cord stimulation, and there's at least 1 or 2 studies about repeated transcranial magnetic stimulation, but they're transient. I mean, so then you'd have to think. And one person dropped out of the transcranial magnetic stimulation because it produced seizures. So these are in experimental stages, and they may work. I mean, so the concept is, I mean, we're learning a lot about treating Parkinson's and tremor and moving into psychiatric conditions by various places of deep brain stimulation. And so that field is expanding in its own direction, and when will that merge into controlling spasticity by specifically placed electrodes? Maybe. It's not there yet. It's being studied.
I'm experiencing some pain and cramping in my big toe. Is this a common occurrence of HSP?
Yes.
What do those with SPG4 have in common, and how does it differ with other SPG numbers?
Yeah, so I can speak about the pediatric cases and the pediatric manifestations, and I think I would come back to 2 concepts I introduced earlier today, which are that there is heterogeneity, meaning that one gene can produce a variety of symptoms in different individuals, and that there are also differences between the common manifestations of several genes that cause HSP. So I think what all have, or most patients will have in common is the lower limb spasticity and weakness. But beyond that, the disorders can be quite different. And I hope I was illustrating that a little bit this morning when I showed a couple of the vignettes. It can range anywhere from really severe spasticity of the arms and legs in the first year of life to very mild spasticity later in life. So that's just a degree of spasticity. And we see a similar spectrum for almost all symptoms. So highly variable. I think there are certain symptoms that are common among different types of HSPs, but in general, there's a lot of variability.
Is depression and anxiety due to HSP? What treatment options are there for this?
Well, so this is a very difficult question because, first of all, in individuals that have any chronic medical condition, whatever it is, liver disease, arthritis, anything, any chronic condition, there is a major psychological consequence for having a chronic condition. And HSP is part of that. People that have and PLS too. So now, in that question is the concept that depression is a manifestation of the biochemical neurologic process that causes HSP. I don't think so. I don't think it's it's part of the disease manifestation. In other words, like spastic lower extremities, spastic bladder, muscle weakness. Those are direct consequences of the condition. Depression and anxiety, I don't think are the direct biochemical neurologic consequences of the condition. I think it's the secondary effects of living with this condition on an emotional basis and seeing how it affects relationships and body image and working and what activities are fun and what activities have used to be fun are now more difficult, and there's a myriad of secondary consequences. I don't think it's a direct consequence of the gene mutation causes anxiety at all. I don't think that. But it's just, I think, part of living with a chronic condition, and that this is shared by other chronic conditions, and I would say by every chronic condition.
Can marijuana help with spasticity? If so, which type? It did not help me. This is not my question, by the way.
So, Greg, we can talk about your experience later. So the answer is yes. There are, I can't give you types or doses, but yes, it has an has an anti-spasticity effect, and it can be used in combination with other anti-spasticity medication. Everything has a pro and a con, and so it can relieve pain and so forth, but it is part of the treatment options for some people.
Will there be or are there any clinical trials for new meds to help mobility?
So can you repeat again? Can you repeat the question again?
Oh, I'm sorry. Will there be any clinical trials for new meds to help mobility?
I can make it. Maybe. So hopefully there will be clinical trials for a new 9. It's called AKV9 now. So one of the outcome measures would be to improve the motor function, which will be quantitatively analyzed by The outcome measure would be motility, motor neuron circuitry and so forth. And I think with the drug discovery platform that we have, and I'm currently working with multiple companies, I think other companies will also try to apply to FDA for their compound to be utilized in the field of HSP-PLS or upper motor neuron or ALS domain. And I would imagine that there will be more compounds coming up for clinical trials for motor neuron diseases, especially upper motor neuron diseases. But of course, we need, like the ALS-FRS score. You remember Dr. Matsumoto talked about the scoring system for upper motor neuron disease, so that's very useful. And with the invention of biomarkers, I think we will have outcome measures. And once we have that, and the engagement of the foundations and patients are also very important, because in the ALS field, you know how vocal they are. They're everywhere. They're like, to the faces of the Congress, they're everywhere, right? And then there's a saying in Turkish, if a baby doesn't cry, they don't give them milk. So if we are not advocating enough, or if you're not, outspoken enough, maybe they will not think that this is an emergency or this is an important disease, and it would be staying as a rare disease. I think with the science and with the advocacy, we would have more treatment options coming up.
Is constipation one of the side effects of HSP, and what treatment options are available?
Yeah, I would say yes, it's a common symptom. I think it's often under-recognized for a long time. And again, there's a spectrum, I think, from constipation all the way to real GI dysmotility and severe GI dysmotility. And I think in general, we take the approach of symptomatic treatment with laxatives first. And in some cases, I've rarely seen this, the GI motility is so severe that other options need to be considered, including surgery. So I think laxatives would be the first approach. And I'm usually quick to send my patients, if it's more complicated, to a gastroenterologist, just because I think sometimes the management or opportunities for managing the symptom are missed for a long time. So I like to establish them quickly with gastroenterology.
Any recommendations for treating progressively weak legs other than exercise?
Well, yes. We need to protect the joints, the knees, the ankles. And so braces are valuable, depending on the circumstance. And also, depending on where there's weakness, there's things like, there's bracing there's electrical stimulation to promote the dorsiflexion of the feet. And that's being expanded in an experimental way to have electrical stimulation to promote the knees being lifted. But bracing is helpful and to preserve the joints, and electrical stimulation for the ankles is possible, and hopefully for hip flexion will come along. But the foundation is exercise, and to reduce the baclofen pump. Because excessive baclofen or excessive oral baclofen or baclofen pump or Xanaflex or any excessive antispasticity medication can exacerbate weakness. So look at medication effects, pursue physical therapy, and so forth.
Is copper deficiency a symptom, cause, or result? And I don't know if this is from someone with HSP or PLS, but for either of those, is copper deficiency an issue?
Copper deficiency, if it's severe, has its own consequences that in some ways can look like HSP. So if a person has severe copper deficiency, that's treatable by giving copper supplementation. But no, copper deficiency can cause severe copper deficiency. I don't mean little copper deficiency, but severe copper deficiency can cause very severe neurologic problems, which can be treated and which can sometimes be reversed, or the progression can be stopped by copper supplementation.
One last question. I see Tim sneaking up and he's pointing one at me. For HSP4, or I think for either of these conditions, the issue of high cholesterol, doctor recommends a statin with muscle side effects and not knowing if it raises or improves that issue. What other inhibitors do you recommend that we might investigate?
I'm just going to answer that question from my personal point of view, and I think I had this conversation with the person who wrote the question. But I have been recommended statin for decades, and just my own personal experience is that it makes me sick. I would stay away from statin if it makes you sick. And finally, what I got my doctor to recommend through a cardiologist is Repatha. Repatha is a twice-a-month injection, and it has no side effects, at least not on me. Anything that's bothering you about statin should not bother you with Repatha. So I'm a big advocate of Repatha. Now keep in mind, I'm not a medical doctor. I'm simply saying that from my own point of view. But I struggle with statins and the constant prescribing of statins by the primary care physician for half my adult life. And Repatha was the solution for me.
Thanks, everybody. But thank you, doctors. Thank you for answering those questions. Everybody, thank you for writing those questions. Thank you very, very much. But don't go nowhere. Sit down. We got a quick special presentation that we want to do. It's going to happen in just a second.